Good afternoon. I am Amanda Janino, Vice President, Business Development for IDSA and the IDSA Foundation. Thank you for joining us today for this non-CME program of our Dr. John G. Bartlett Memorial Education Series. From Diagnosis to Treatment, Navigating the NTM Treatment Landscape. And a special thank you to our webinar supporter, INSMED. Before I turn the program over to our host and moderator, I do have a few housekeeping matters. This webinar is being recorded and will be available on demand. A link will be emailed to all registrants within 3 business days, or you may access a recording and share it via our website in the IDSA Foundation YouTube channel. You'll notice that your microphones are automatically muted. There will be a dedicated Q&A session at the end of the presentations today. If we can't get to all of your questions during the live event, we will make sure to do our best to address them in the follow-up email. Now, I would like to introduce our moderator for today, Dr. Doreen Abrizo-Harris. Dr. Abrizo-Harris is a pulmonary critical care physician with an extensive background in bronchiectasis and NTM infections and medical education. She is currently a professor of medicine at the NYU Grossman School of Medicine. She serves as the Associate Director for Clinical and Academic Affairs and is a co-director of the Bronchiectasis and NTM Clinical and Translational Program. She is now serving her 23rd year as a program director of NYU's Pulmonary and Critical Care Medicine Fellowship. She has served as the chair of the 6th World Bronchiectasis and NTM Conference in 2023 and is chairing the first North American Bronchiectasis and NTM Symposium this December in New York City. She is the immediate past president of the American College of Chest Physicians and currently serves as the chairperson for the Bronchiectasis Clinical Care Network Steering Committee for the COPD Foundation. She is PI of many clinical trials and is a passionate educator on the topic of bronchiectasis and NTM. Dr. Abrizo-Harris, welcome. We are so glad to have you, and I'll turn it to you.
Thank you so much, Amanda. I am here today moderating for you with my COPD Foundation hat on and representing the Bronchiectasis and NTM 360 section of the COPD Foundation. We will tell you more about that later today. But I'm very excited that we have 2 phenomenal speakers who are going to be talking to us on bronchiectasis and nontuberculous mycobacterium. And they will be letting us know the impact that these diseases have on our patients, how to diagnose it, how to treat these diseases, and will really help us connect NTM and bronchiectasis from a pathophysiology standpoint. We have several learning objectives today. Next slide. And we will be going through a number of these topics, hoping to examine the epidemiology of NTM lung disease, contrasting NTM and bronchiectasis in terms of the pathophysiology, evaluating the demographics and clinical characteristics that increase susceptibility to NTM, and summarizing the effects on NTM on lung health, as well as reviewing treatment guidelines that will hopefully help you in your care of these patients on a daily basis. Now it is my pleasure to introduce our first speaker, Dr. Elisa Ignatius. Dr. Ignatius is Assistant Professor of Medicine in the Divisions of Infectious Disease and Clinical Pharmacology and Program Director for the Johns Hopkins Center for Nontuberculous Mycobacterium and Bronchiectasis. She received her undergraduate degree from Columbia University, her medical degree from Emory University, and her Master's of Science from the London School of Hygiene and Tropical Medicine. She completed internal medicine training at Emory and her postdoctoral fellowships in infectious disease and clinical pharmacology at Johns Hopkins. She provides care for patients with NTM, bronchiectasis, and other infectious diseases. Her research focuses on treatment optimization for mycobacterial infections, including novel and standard drugs. Thank you, Dr. Ignatius, for joining us today.
Thank you, Dr. Abrizo-Harris. So I'll start by providing a brief overview of nontuberculous mycobacterial lung diseases. NTM around the world are diverse, though there are some predilection for certain subspecies being more common in certain parts of the world. As many on the call may know, mycobacterial species are divided into what we call slow growers and rapid growers. Slow growers typically turn positive in culture in fewer than 7 days, usually a range of 3 to 10 days, while slow growers take more than 7 days, often many weeks, to become positive in culture. And on the left-hand side is a phylogenetic tree summarizing those slow growers and rapid growers. The rapid growers are those in the blue dots, the slow growers are those in the red dots. And you can see it's an incredibly diverse and broad set of species of NTM organisms that have been identified around the world. But as I mentioned, on the right-hand side, you can see that certain subspecies or complexes of these organisms do have a tendency to be more or less prevalent in certain parts of the world. So you can see that across these different contexts from this study, Mycobacterium avium complex, or MAC, was the best represented, with estimates ranging between 30% up to 50% of the isolates fell into this Mycobacterium avium complex group. But the other subspecies really varied pretty dramatically in terms of the proportion of the remaining NTM cases that they made up. So you can see, for example, in South America, Mycobacterium kansasii was observed in about 20% of isolates. In other contexts, such as Asia, the rapid grower Mycobacterium were quite common at around 31%. So it really depends on where you are in the world, what is the most likely infecting NTM species that you could see in your patients. Next slide, please. But these are environmental organisms, as I've mentioned. So they're in all of our soil, all of our water. And the table on the right-hand side summarizes some of the environmental or the domestic spaces where these NTM organisms can be identified. So they're in all different types of soil. We see them in drainage waters, but we also see them inside of our own homes. So have been isolated from water and ice machines and refrigerators, from activated charcoal filters, from indoor humidifiers and the aerosols that they produce, and from indoor swimming pools. So these really are everywhere in our environment. And the route of exposure that causes human infection is primarily through aerosolization or inhalation and swallowing or aspiration, so in the form of water or liquids or food that we ingest. Additionally, there's a less common manifestation of NTM infections, which we won't be talking about as much today, which are the non-pulmonary or extrapulmonary NTM infections. And these are when these NTM species are directly introduced into wounds. And this can be in the form of a traumatic injury, or an accident, or it can be intraoperatively during the course of surgery. Next slide, please. Because these are ubiquitous environmental organisms, it can sometimes be challenging for the clinician to disentangle, does isolation of one of these organisms signify a bystander or a colonizing organism, or is this a true persistent infection that might benefit from treatment? And I think to underscore that are a few data that I'll present here. So on the left-hand side of the slide, you'll see one study that summarized the proportion of isolates by species that were first deemed clinically significant. Those are the blue bars, and those that were clinically significant and treated. And what you can already see is that certain species tend to have a higher proportion deemed clinically significant. So you can see on the far right-hand side of that bar graph is Mycobacterium abscessus, one of the organisms that we think of as being more pathogenic, can present in a somewhat more fulminant way. And then you can also see that the vast majority of those Mycobacterium abscessus clinically significant isolates were also treated. So a larger proportion, the clinician did deem that that treatment might benefit for the patient. You can see other subspecies, for example, Mycobacterium zenopi, only about 39% were deemed clinically significant, and a far lower proportion, about 19%, were deemed clinically significant and treated. Mycobacterium kansasii, just as another example to highlight, only about 27% were deemed clinically significant, but all of those were treated. And telling a similar part of the same story is the table on the right-hand side, which is a study where they looked at the proportion of these isolates which were smear positive at the time of identification. Again, speaking somewhat to the pathogenicity of some of these organisms. And you can see again that these estimates differed dramatically by subspecies. So Mycobacterium abscessus in this study, 63% of those isolates were smear positive, suggesting a much higher burden of infection. That's in comparison to Mycobacterium avium, where only about about 6 to 7% of the isolates were smear positive. So while these are not absolute rules, this I think helps contextualize a bit the pathogenicity, the likelihood that isolation is going to signify treatment, but you really need to look at the whole picture in order to make that determination as the clinician. Next slide, please. So before launching into the next section here, which is really exploring some of the host susceptibilities to NTM lung disease, I just wanted to underscore the fact that as clinicians seeing patients with NTM, we really should think of the identification of NTM, the diagnosis of NTM lung disease as being the tip of the iceberg. And really, when we have a patient in front of us who we've determined does have a true NTM infection, may benefit from antibiotic therapy, we also should have an entire cascade of diagnostic and therapeutic next steps that are triggered just by virtue of the fact that this person is presenting with NTM lung disease. Next slide, please. So first is to really understand all of the patient characteristics that can conspire to put your patient at risk for this opportunistic infection, NTM lung disease. And this is a surprisingly diverse set of patient conditions that can put an individual at risk for this opportunistic infection. And we'll talk about some of these in greater detail, but this sort of provides a broad overview of some of the conditions that we often identify in our patients. Bronchiectasis, I'll talk about more in a couple of slides, is a profoundly powerful risk factor for the development of NTM lung disease. We see a number of genetic conditions like cystic fibrosis or CFTR anomalies, primary ciliary dyskinesia or PCD. We also diagnose many of our patients with exogenous, iatrogenic immunosuppression. That is what conferred the risk of developing NTM lung disease, but also with endogenous forms of immunodeficiencies, things that they were born with or things that they acquired over the course of their life that made them more susceptible to these types of environmental organisms. Alpha-1 antitrypsin deficiency, COPD, asthma, pneumoconiosis, collagen vascular disease, alveolar proteinosis, pulmonary fibrosis, post-TB lung disease is very well described as a predisposing risk factor for NTM lung disease. And then the sort of classic Lady Windermere phenotype, this being postmenopausal Caucasian women, tend to be lower weight, taller in stature, often with thoracic skeletal anomalies, scoliosis, pectus excavatum, mitral valve prolapse, who seem to be extremely predisposed to developing right middle lobe and lingular bronchiectasis and NTM infections. Next slide, please. We also know that age is a very well-established risk factor for developing NTM lung disease. And that's sort of summarized on this figure here. And what you can see is that age greater than 65, those are the kind of gray stars, had a much higher number of cases per 100,000 persons than those under 65 in the orange squares. This is represented in a somewhat different way by comparing Medicare, those are the purple crosses, to commercial insurance in the blue circles, but receipt of Medicare obviously being a surrogate for age. So age is certainly associated with an increased risk of NTM lung disease. We also know, as I alluded to before, that this is a much more common phenomenon in women than it is in men, women here being the blue inverted triangles and men being the orange upright triangles. We can also see, just another point to highlight from this figure, that there's been an increase in these cases over time. And it does seem that this increase in the number of cases that we're seeing, it is outpacing merely diagnostic awareness or diagnostic capacity. So it's not just that clinicians are talking about this more. It's not just that our labs are better equipped to readily identify these organisms and perform drug susceptibility testing. It's that there actually does seem to be a true increase in these numbers. And this isn't just in the United States. This has been observed in multiple contexts around the world. And there's likely a number of reasons for that. Climate change may be at play, but just to highlight for this audience that this is likely a clinical scenario that we will continue to encounter in our practice more and more in the years to come. Next slide, please. So I already mentioned that Medicare recipients have a higher rate of these infections than commercial insurance recipients. So the rates of about 112 patients per 100,000 persons. And among veterans with COPD, another particular risk group, we see that rate increases somewhat to about 150 patients per 100,000. There have also been a few studies that have suggested that administration of inhaled corticosteroids does further increase that risk. One study found that a prior use of inhaled corticosteroid increased the odds ratio of NTM lung disease up to around 20, and then with current inhaled corticosteroid use, it was as high as 30. I will just note that there's likely some confounding by indication, going on in these studies, but nonetheless an important signal. And in our patients, if a patient doesn't absolutely need an inhaled corticosteroid because of their physiology, we do discuss whether or not it can be safely tapered and eventually stopped. We also know that cystic fibrosis is a very well-established risk factor for NTM lung disease. One study found that among 16,000 patients with CF, 20% had had a pathogenic NTM species isolated at least once over the last 5 years. And the table on the right-hand side kind of underscores a point I've made and will continue to make a few more times, which is that bronchiectasis really is above and beyond the greatest risk factor for developing pulmonary NTM infection. And they have a cyclical dynamic between them. So pre-existing bronchiectasis increases the risk of developing incident NTM lung disease. And conversely, if an NTM establishes itself in the lungs, it can then cause bronchiectasis in its wake. So they feed off of each other. There's been a number of other risk factors that have been described across multiple different studies, including lung cancer, COPD. I mentioned those thoracic skeletal anomalies, low body weight. We know that low body weight is associated with developing NTM, but also among patients with NTM lung disease who have low body weight or low BMI, their prognosis is worse. So tend to progress more and have generally worse outcomes. So it's a very important kind of part of the history that we assess when patients are presenting with NTM lung disease. And we often will refer to a nutritionist to improve their nutrition, help them gain weight in a healthy way in order to help them fight off this infection. A number of autoimmune diseases, including rheumatoid arthritis, are associated with NTM lung disease, as well as many of the medications we prescribe, anti-TNF-alpha inhibitors, steroids, and then reflux is also a very well-established risk factor for NTM lung disease, as well as bronchiectasis. Next slide. So bronchiectasis, I keep mentioning it because it is so important to the risk sort of stratification for NTM lung disease, and potentially treating NTM lung disease could slow progression of bronchiectasis if it is present. And so bronchiectasis is really this deleterious cycle of inflammation that leads to airway destruction and distortion, which then impairs normal mucociliary clearance, creating stasis of the mucus, which then permits various opportunistic organisms, bacteria, mycobacteria, fungal organisms, permits them to persist and potentially establish as chronic infections, and then the cycle repeats. So really the main intervention that we have in our armamentarium for the moment is airway clearance for bronchiectasis. And though I know this is a talk on NTM lung disease, it really is essential that we talk about the management strategies for bronchiectasis, because it can have an impact on the mycobacterial burden, and it really should be implemented, if appropriate, concurrently with NTM antibiotic treatment. And so what this airway clearance can look like for a typical patient may consist of a bronchodilator. It almost always consists of hypertonic saline, 3 or 7%, that's nebulized into the lungs, and then some sort of a vibration treatment. And that might be a positive expiratory pressure device, aerobica or acapella that helps to shear the mucus off the lining of the airways. It may be in high frequency chest wall oscillation vest that serves a similar purpose. And then that whole sequence is ended with a huff cough that is often our respiratory therapists or our physical therapists instruct these patients in how to perform this technique to expel the mucus, from the lungs. So really important to assess for the presence of bronchiectasis in these patients, teach these techniques if the patients are amenable. Of course, there are pros and cons. It can be time consuming. It can require a certain amount of dexterity that not all of our patients have. But by and large, we really do encourage the use of some form of airway clearance therapy in parallel with treatment of their NTM lung disease. We also work to name and mitigate whatever other insults may be causing chronic lung inflammation, such as reflux, such as chronic sinusitis. And this is partly from to limit the amount of inflammation that these processes are causing to the lungs, but they can also serve as a means of inoculating the lungs with infectious organisms over time. So really serve both of those purposes. And of course, in folks with bronchiectasis, we survey for other incident infections and treat with antibiotics when necessary. Next slide, please. And this is a similar, kind of discussion point, which pulled from a recent review of bronchiectasis in the New England Journal of Medicine, which is just certain historical findings when you're discussing with your patient that should trigger the clinician to potentially explore other diseases in parallel with deciding whether or not to treat the patient in front of them for their NTM infection. And so certain historical elements that should automatically trigger that the clinician should automatically take note of would include things like fairly early onset of disease, sinusitis, pancreatitis, infertility, either male or female, history of neonatal respiratory distress, frequent otitis media, emphysema in the absence of a smoking history, and then a number of other symptoms and signs, joint stiffness, dysphagia, reflux, which could signify or be suggestive of an underlying autoimmune disease. For patients that have had prior head and neck cancers and received radiation to that region, there can be some vocal cord dysfunction or esophageal dysmotility, both of which can predispose to NTM and bronchiectasis. So really important to take a very thorough history, as I know all infectious disease clinicians do, and potentially initiate or refer to other subspecialists who can initiate some of these workups for these other diseases, because identifying them may have a different management strategy that could on net improve lung health, improve immune resiliency, and potentially lessen the mycobacterial burden as well. Next slide, please. Okay, so we've talked about kind of the host susceptibilities, the epidemiology. Moving on now to how do we diagnose a patient with NTM lung disease? And there are criteria that have been established by the American Thoracic Society, ATS, and the Infectious Disease Society of America, IDSA, in collaboration. And these are clinical, radiographic, and microbiologic criteria. So the clinical criteria are pulmonary or systemic symptoms, and it can really be either, and we see it all. So some patients have entirely pulmonary syndromes. They come in with cough, hemoptysis, progressive dyspnea, new onset sputum production. But others really have very minimal respiratory symptoms, and it's primarily these systemic symptoms. So night sweats, unintentional weight loss, fatigue. Radiographically, there can also be a spectrum. So some patients have more bronchiectatic nodular phenotype. Others, there's these large cavitary opacities like what we would see with tuberculosis. Microbiologic, patients have to have at least 2 expectorated sputum samples growing the same organism. If you could go back, thank you. Or a single deeper bronchioalveolar lavage would suffice to meet this criteria. Also, if a patient has had a transbronchial or other lung biopsy and it grows the organism and also has suggestive features on pathology like granulomas or visible AFB positive organisms on staining, that would also meet the microbiologic criteria. Next slide, please. I mentioned that there can be a variety of different symptoms that patients can present with who have NTM lung disease, but I think important to underscore that the most common presenting symptom that patients have is fatigue, 83% of patients in this one study. So this is a symptom that, though it's obviously nonspecific in the correct clinical context, should prompt a clinician to start an investigation for whether or not there could be NTM lung disease present. Others I've mentioned: cough, sputum production, shortness of breath, night sweats, fever, hemoptysis, weight loss, in that order. But because some of these symptoms can be so subtle and indolent and nonspecific, there is a considerable diagnostic delay for many patients. So the median time from symptom onset to diagnosis of NTM lung disease is over 2 years. Next slide, please. On the microbiologic criteria, a couple points that I just wanted to highlight, which is that we think of bronchoscopy, it's this invasive test, it's got to be better yield. And in many situations, it is the only way that we do end up diagnosing somebody with NTM lung disease. But there are some caveats. Bronchoscopy specimens are not as great as we might think. So for one, the lidocaine that's used in the course of the procedure is bacteriostatic. So that alone may be reducing your mycobacterial yield somewhat. By virtue of how the procedure is done with instilling saline into the lungs, the specimen can be diluted. There can be sampling error. You're not as reliably able to determine the bacterial load. And obviously, there are inherent risks and costs to performing this invasive procedure. And sputum may be better than we give it credit for, particularly if you're collecting multiple specimens over many weeks. The yield is actually quite good. Additionally, from serial sputum samples, we can get helpful prognostic information like smear positive status and the number of cultures over time that are positive for this organism. That can be useful prognostic data for yourself as the clinician, but also for patients. And it's got similar yield as bronchoscopy in tuberculosis and non-tuberculous mycobacterium. And finally, induction with hypertonic saline can increase the yield of sputum, and it's easy. As I mentioned, we teach many of our patients, if not most of our patients, how to do airway clearance, which does involve the self-administration of hypertonic saline. So this is a really helpful tool that can increase the yield, potentially expedite diagnosis, avoid a costly and potentially risky procedure to your patient. Next slide, please. And again, on the kind of microbiology front, we get a lot of data as we're collecting these specimens. So ideally, we have multiple specimens that are collected serially over a number of weeks. We get that smear microscopy data instantly in the first day. Culture can take, less than a week or up to many weeks to return. And then depending on your laboratory capacity and the ability to do some molecular diagnostic testing, you could have identification, within a day or two, up to a few weeks. It's also important to remember that for many commercial labs, drug susceptibility testing for mycobacterial isolates is not done routinely. So if you have a patient where you have this clinical suspicion, you really need to be very aware of where that specimen is and whether or not it has turned positive so that you can request the susceptibility testing quickly before the specimen is discarded. Next slide, please. And finally, on the radiographic front, there is, as I mentioned before, a range of ways in which this can present. And this has implications for how we treat the disease. So as Dr. Daly will go into in greater depth, cavitary disease, that's shown on the upper right image here, it does generally suggest a higher burden of infection, more severe disease for which treatment would be intensified. There's also the more bronchiectatic or nodular phenotype, as you can see on the bottom left side there. And another important thing is that the distribution of the disease, of the bronchiectasis, of the nodular lesions, can also sometimes suggest the other underlying predisposing risk factors that patient might have. So lower lobe disease tends to suggest reflux, dysphagia, chronic sinusitis, different types of immunodeficiencies, inflammatory bowel disease like Crohn's, primary ciliary dyskinesia, alpha-1 antitrypsin deficiency. While upper lobe disease, we tend to see more in cystic fibrosis, ABPA, sarcoidosis. So again, while not hard and fast, the distribution of abnormalities on CT can also point you in one diagnostic path or another. And with that, I will hand it over. Thank you.
Thank you very much, Dr. Ignatius, for that wonderful overview. It is now my pleasure to introduce you to Dr. Charles Chuck Daly. Dr. Daly is Chief of the Division of Mycobacterial and Respiratory Infections at National Jewish Health and Professor of Medicine at National Jewish Health as well, and the University of Colorado and Icahn School of Medicine at Mount Sinai. Prior to coming to National Jewish, he was medical director of the Curry Training Center at the University of California, San Francisco. Dr. Daly has served on and chaired expert panels for the World Health Organization, Centers for Disease Control and Prevention, in Infectious Disease Societies of America, and the ATS. He has chaired the revision of the multi-society sponsored NTM treatment guideline that came out in 2020. And he is known for his work with MDR-TB, where he was awarded the World Lung Health Award by the ATS. He was previously associate editor of the American Journal of Respiratory and Critical Care Medicine and the European Respiratory Journal, and is now associate editor of Frontiers in Tuberculosis. His academic interests include TB global health policy and clinical and translational research related to TB, NTM infections, and bronchiectasis. And we are thrilled to have him today. Welcome, Dr. Daly.
Thank you, Doreen. Next. So we're going to switch gears and now focus on the treatment of non-tuberculous mycobacteria. Next. The first guideline from ATS was published in 1990. We're now on the third revision, which was in 2020. And most of the things that I'll be citing as evidence relate to those guidelines. Also note, though, in 2022, we published a consensus document. And this is just for your information. We won't talk about that today. But this document has some of the more rare pulmonary NTM. So things like chelonae, fortuitum, simii, those kind of things. So if you're looking for some recommendations to treat those more rare NTM, that's where you'll find some data. Next. So the first question is, why do we want to diagnose and treat NTM lung disease? I'll show you in more detail in a minute, but disease progression occurs in most patients, usually in a fairly short time frame, like 3 to 5 years, and those who meet the ATS IDSA criteria that Elisa reviewed. You should also note there are at least two studies that have shown in untreated patients, lung function declines over time. There's impaired quality of life and it actually improves with therapy. There's also an increase in mortality. The 5-year all-cause mortality can be as high as 33%. And in that one study, they showed that the untreated patients had a higher mortality than treated patients. And it's also a very expensive disease. It's been equated to the cost of caring for AIDS patients. So there are multiple reasons that we want to find our patients with NTM and initiate treatment. Next. So the first question is, who do you start treatment on? This is a very difficult part of the care of these patients. Do you go into what's been termed watchful waiting, or do you start treatment? In the guideline, we suggested that you should start treatment rather than watchful waiting, but particularly in the context of people who have a high bacillary load, like a positive smear, or they have cavitary disease. Next. These are 3 studies that really get to that point. They're fairly large, 500 to 1,000 patients. So these studies are from Korea, and they met the ATS IDSA criteria. So these are the people that in clinic you're thinking, should I treat? They were followed for a median of 4 to about 6 years, and the majority did progress during that time frame and go on treatment. But you can see a sizable portion, a quarter to 45%, were stable during that time frame, and anywhere from 34 to 52% spontaneously converted their cultures back to negative. So those same studies, no, you can go ahead. Those same studies were able to give us some idea of the risk factors for progression, since they were following patients off of antimicrobial therapy. And so see, these are some of the ones that I use in clinic. Host demographic factors associated with progression would be male gender, older age, presence of comorbidities, and low body mass index. In these studies, that was less than 18.5. There are also laboratory issues that are associated with progression, like elevated inflammatory indices, anemia, low albumin. Radiographic factors such as fibrocavitary disease, and just the overall extent of disease in terms of the number of lobes involved. Very important clinically is the bacterial load, and you can measure this by looking at whether they're smear positive or not. Do they have high semi-quantitative culture results if you have those available, or even just the number of cultures over time. And then the species. We know that not all species harm humans, and even within MAC, the 10 different species within MAC, there's some variability in pathogenicity. Next. So if you have a patient who meets the 3 disease criteria, you need to consider, should I treat this patient? So we go through the process. We review those risk factors for progression. Is this a patient that has none, or is this a patient that has a lot of risk factors for progression? We review the risk and benefits of treatment with the patient and try to assess the patient's preferences here. Next. If you choose watchful waiting, which is a reasonable thing to do in many patients, it still means you're going to be doing something. You're not really just watching. And the good news here is patients with NTM and bronchiectasis, usually this is an indolent disease. You have time to make the right decision. So for example, in patients with bronchiectasis, get them started on airway clearance, as we heard. This is a very important component of treating them. And we have seen patients even convert their cultures to negative with just starting airway clearance. But it also gives you time to really optimize the management of the other comorbidities, many of which may be causing some of their symptoms. For example, GERD, sinus disease, other lung disease. Nutrition, very important. Low BMI is a risk factor for progression. So this is a time that we will try to improve nutrition while we're in this watchful waiting period. Next. But does it hurt our patient to delay therapy? This study suggests in this time frame, no. This was a retrospective cohort from Korea that looked at 712 patients who had received antibiotics for 6 or more months for their NTM pulmonary disease. Now, exactly when treatment started was totally up to the attending, and some of the attendings at this institution did use this watchful waiting approach. So the median waiting time, meaning the interval from diagnosis to treatment, was about almost 5 months. And the good news is there was no association between the waiting period and whether they converted at 6 months or in terms of death. Now, in those who did get treated on or did get started on treatment, almost 70% converted within 6 months. That's very similar to what has been published elsewhere. And conversion within 6 months, though, was associated with reduced mortality. So the conclusion from the authors was that it's reasonable to start with a watchful waiting strategy, but given the survival benefits, if you do start treatment, you really are trying to achieve culture conversion because of the decreased mortality. Next. So if you're going to treat, then you need to decide which regimen, and that's going to be based on the phenotype. In nodular bronchiectatic disease, we recommend 3 drugs, macrolide-based regimen, azithromycin preferred, and you can give it 3 times weekly. If they have cavitary disease, we recommend 3 or more drugs, and that 4th drug is usually parenteral amikacin. In this setting, we give the oral drugs daily, but we feel you can give the aminoglycoside 3 times a week. And in both phenotypes, we're trying to achieve 12 months of culture negativity before we stop treatment. Next. So this is what you would expect in terms of outcomes. In a macrolide susceptible MAC patient who has non-cavitary disease, about 70 to 80% will culture convert. In cavitary disease, that has been reported to be as low as 50%. I would say it is typically lower than in non-cavitary disease. And both groups have high recurrence rate, microbiologic recurrence, anywhere from 1/4 to 1/2. And most of those are going to be reinfection, anywhere from almost 50 to 75% of the time. In the setting of macrolide resistance, things are quite different. David Griffith published many years ago these results of 5% culture conversion in macrolide resistant cases if they didn't have surgical resection and if they did not receive a prolonged aminoglycoside course. In a study that I was involved in Korea, we got it up to about 15% culture conversion by doing some surgery and use of aminoglycosides. And in that original study by Dave Griffith, if patients did have surgical resection and 6 or more months of an aminoglycoside, he could get the culture conversion back up to about 80%, but at great cost to the patient, meaning they had ototoxicity and, of course, surgery. Next. So we know that not everyone responds. There are treatment failures. And in the 2020 guidelines, we define this as treatment refractory disease. And that is a patient who remains culture positive after at least 6 months of guideline-based therapy. So we recommend that you do frequent culture so that you can determine precisely the duration of therapy and ultimately whether this patient is responding to treatment. And if you get out to 6 months and they're still culture positive, the guidelines recommend adding amikacin liposome inhalation suspension or ALIS to guideline-based therapy. Next. And this is based on 2 randomized studies, including this phase 3 randomized trial in patients who did have treatment refractory MAC. It's called the CONVERT trial. People who received ALIS plus guideline-based therapy had about a 30% culture conversion rate within 6 months, with only 9% of those who got culture guideline-based therapy alone. Next. Now let me switch to Mycobacterium abscessus. This is an organism, his name continues to change. Abscessus was identified in the knee and subcutaneous buttocks of this patient in 1953. It wasn't named until 1992, M. abscessus. 2006, Adekambi said this is not 1 species, but 3 species, abscessus, macilliense, and belledii. There was a naming violation called, so M. macilliense was retracted, and clinically speaking, they were collapsed into a new subspecies, belledii. We did not think that was correct, and in 2013, we published a paper with my Korean colleagues recommending it be split into 3 subspecies, abscessus, macilliense, and belledii. That was confirmed by another group in 2016. So that is currently what it is considered correct. Now, there's a little twist to the story, and that is in 2018, Gupta recommended the genus Mycobacteria be broken into 5 genera, including 4 novel ones. And so that impacted abscessus because that put abscessus under a new genus called Mycobacterioides. That has been accepted. but in taxonomic terms, once named, always named. So Mycobacterium abscessus or Mycobacterioides abscessus are both considered appropriate. Next. So macrolide resistance is critical to understand in abscessus, just like it is with MAC. There are two forms of resistance. One is mutational. Mutation in the RRL gene results in high-level constitutive resistance. Next. More common, though, is inducible resistance. And in this setting, it's due to erythromycin ribosomal methylase gene, specifically ERM41. Looks like about 80% of subspecies abscessus has a functional ERM gene. And that means inducible macrolide resistance will occur in that setting. Myceliense, we call that the good abscessus because it has an ERM gene, but it's truncated, non-functional. So there is no inducible resistance. And Bartlettii behaves like abscessus with a functional ERM gene in all the ones that we've tested. Next. Now you can detect this in the laboratory, in the clinical laboratory, through sequencing, a line probe assay, or you can do a 14-day incubation. Next. So let's look at how we might interpret that information. If you read at day 3 to 5 and day 14 and the isolate is susceptible to the macrolide, in this case, clarithromycin, that is a dysfunctional ERM gene, probably Myceliense. It is macrolide susceptible, and by all means use the macrolide to treat the patient. If it's susceptible in the first read, but resistant at day 14, that is a functional ERM gene, probably abscessus or Bartlettii. This means there is inducible macrolide resistance, and you cannot count on that as an active agent. Perhaps it's still doing something in terms of an immunomodulatory, but you wouldn't count it as part of their active treatment regimen. And if it's resistant on day 1, then there's 23S ribosomal RNA point mutation. This can occur with any species, particularly if they've been exposed to the macrolides. This is constitutive high-level macrolide resistance. So again, would not use the macrolide. Next. So this is the complex approach, unfortunately, to abscessus. But just like with MAC, the macrolide is a critical question. Is it susceptible or not? And if it is susceptible, meaning there's no macrolide resistance, the recommendation is to give 3 or more drugs, picking 2 or 3 from the parenteral list here and then oral list. Give this for 2 or so months, depending on tolerance and response to therapy, and then typically de-escalate after that to 2 oral drugs and often inhaled amikase. If resistance is present, this is going to be a difficult case to treat and to achieve culture conversion. So we just say try 4 or more drugs, but the approach is otherwise the same. Next. Next. So we participated in this individual patient meta-analysis, of which there were 8 studies, about 300 patients. If you looked at treatment success and you didn't subspeciate, you just looked at abscessus group, it would be about 46% treatment success. In the studies that were able to subspeciate and look at abscessus alone, it was 33%, so very low treatment success. Myceliense was higher, 56.7, but in the forest plot at the bottom, you can see that some of the studies had no data, so this is really based on very little information. Factors that were associated with treatment success, use of imipenem, azithromycin, and parenteral amikase. Next. So this is a very common problem, which is treatment refractory abscessus. We can't culture convert the patient. This is a recent study from Korea that looked at 36 patients who were still culture positive after a year of therapy. So 12 months is how they defined it. What they did is they admitted patients to the hospital periodically, usually for a month, and give them IV therapy with imipenem, amikase, and tigecycline, in addition to their oral regimen, which usually was about 3 oral medications. If you look at what happened, median number of hospitalizations was 2 for abscessus and 1 for Myceliense. If you looked at the microbiologic response, culture conversion was very low, 12% for abscessus, but up to 60% for Myceliense. Patients improved symptomatically, and many of them improved radiographically. So this idea that you could periodically, much like we do with Pseudomonas infections, treat patients with a more intensive IV regimen, looks like it does have some benefit for some patients. Next. So I'll end with this. Because clearly we don't have enough now to treat our patients to cure. These are the phase 1 through 3 trials that are ongoing or about to start. And I've highlighted those with an asterisk that have abscessus activity, which is where we greatly need new drugs. But we're optimistic that we're going to have some new drugs in the not too distant future that will hopefully improve our treatment success in our patients with NTM. Thank you. Back to you, Doreen.
Thank you, Dr. Daly. That was great. Now it was my pleasure to introduce our patient representative, John Torrance. John is an NTM and bronchiectasis patient. He started coughing many years ago in 2009 and spent the next 3 years searching for an accurate diagnosis. He has been through 4 treatment cycles for various forms of NTM over the last 12 years, including 16 antibiotics, 15 doctors, 4 inhalers, 3 nebulizers, 2 vibrating vests, 1 lung surgery, and many cross-country medical trips. Today, John works with the COPD Foundation as a patient ambassador, helping industry and medical professionals understand the life of a patient, as well as working with new patients, helping them to adjust to life with their chronic rare disease. Thank you, John, for joining us. Welcome.
Thank you, Dr. Adrizo Harris. I marked my 50th birthday by coughing. I didn't think much of it at first. I thought maybe it was just a cold or a flu. I didn't realize at the time that my whole world was about to change. The cough persisted. I got to know every cold, flu, and cough medicine at the drugstore, but to no avail. I started taking naps in the afternoon, but I didn't relate that back to the cough. When the cough lasted more than a year, I started looking for environmental triggers. I changed my diet multiple times, thinking maybe it was allergies. I looked for triggers from inhaled dust, pollens, and other pollutants. I'd been losing weight, 30 pounds in fact, but again, I didn't relate that back to the cough and now the fatigue. After 2 years of this, I finally decided to take my complaint to a doctor. He sent me home with 10 days of doxycycline, but that was no help. A couple months later, I returned to get a Z-Pak, and again, no help. A couple months after that, I remembered coughing so hard one day that I was completely exhausted. I didn't have an appointment. I just went to the clinic and insisted that a doctor see me. I think the fact that I was visibly upset and exhausted got the doctor's attention. A chest x-ray showed a nodule on my lungs. The doctor thought it might be lung cancer, so she sent me for a battery of tests, including a CT, a PET scan, blood tests. They were all inconclusive. Finally, sputum tests indicated NTM. Somewhere along the line, I was transferred into pulmonology. The pulmonologist explained that I have NTM, an incredibly rare bacterial infection of the lung, and it's going to require a long course of multiple antibiotics. As he gave me more details, I told him I had heard all this information somewhere before. I called my mom and asked her about her funny lung condition that she had talked about. She said she had the same thing. She said to ask the doctor about this other condition called bronchiectasis. So I did ask at my next appointment. The doctor kept his head buried in the computer and never answered me. But the after visit summary now said that I had acute exacerbations of bronchiectasis. I get the impression that he was not familiar with this condition. So I was transferred to infectious disease. I was plumbed with a PICC line. I was sent home with a case of IV medicine, a nebulizer, and an IV machine. My life as a science experiment had begun. I had twice weekly blood tests, weekly bandage changes, daily vomiting, weakness, and the not so fun airway clearance exercises to do. My doctor recommended I go to the experts at National Jewish Health because they were one of the best centers in the country for this condition. National Jewish repeated most of the tests that I had done previously, and then they concluded that I needed to have the upper right lobe of my lung removed because of the damage from the bronchiectasis, the condition that I had to convince my pulmonologist to look for. Surgery was scheduled for the next week. It was a remote procedure called VATS that promised a relatively quick recovery. I made it home a few days later. All of this put a strain on my marriage. Luckily, my work was mostly at the computer, so I could do that, but I could see my world was crashing down around me. I eventually cleared the bacterial infection, but the marriage didn't survive. I lost the wife, I lost the house, I lost the dog, I lost my scuba diving friends, and I moved to the desert of Las Vegas, Nevada. The doctor said I needed dry air. I realized I needed to find the best doctors in the country. I researched family connections in bronchiectasis and found there was a genetic study being done at the National Institutes of Health. I applied along with my mom, and we were accepted. We flew to Bethesda, Maryland for a full workup. Mom has since passed away, but I continue to get the best possible care at NIH. My sister has since been diagnosed with bronchiectasis, and she's in the study as well. I'm convinced some of my cousins are affected, but they haven't joined us yet. As Dr. Drizo-Harris mentioned, I've had more NTM infections. Each one's about a 2-year cycle of drugs, CT scans, blood tests, airway clearance exercises. The dry desert air led to a rare NTM infection unique to the Southwest and particularly hard to treat. The toxicity of the medicine has damaged my hearing to the point that I now have hearing aids. It's been 15 years since that first coughed. At least now I have balance in my life. New friends, new hobbies, new routines. I don't fear the disease anymore. I try to do something non-medical every day, so I'm not just that science experiment. Today, I get great benefit and great therapy from working with the COPD Foundation. I talk to new patients. I moderate a monthly patient support meeting, and I work in groups helping hospitals, pharmacy, and industry develop better answers for tomorrow's patients. I'm grateful to the infectious disease specialists, their teams, and many others who have helped me in this lonely journey towards resolution. If I had 3 wishes, they would be, please take a family history of lung disease early in the process. Include generous amounts of time for respiratory therapists to teach us how to do airway clearance effectively. And let's continue the development for a better treatment for bronchiectasis and NTM. Back to you, Dr. Drizo-Harris.
John, thank you for that wonderful, wonderful story and allowing us into your life and what you've had to go through for the last 15 years. I'd like to welcome everybody back to the screen, Dr. Daly, Dr. Ignatius, John. We are near the end, but I want to have some time for Q&A. There's a few questions in the question and answer area, and I'd like to propose them to our panel. So a few of them relate to the question about what do you do when a patient is unable to produce sputum and doesn't have a cough? I already know what Dr. Daly's answer is going to be. He's going to say just induce that sputum and you will get it no matter what. But what if they do try and induce them and they still can't get sputum, particularly someone's asking for a first-time diagnosis, abnormal CT, pulmonary symptoms, but they just can't get sputum? Should they go on to bronchoscopy?
Are you asking me first?
Sure, Chuck, we'll go with you
Okay.
first.
Yeah, well, so you have to look at the whole picture. If everything is going well, CT is improving, symptoms are improving, why do you need a culture? No, I would never put someone under a bronchoscopic procedure if they're doing well. Now, if we flip it and say, no, the CT has some progression, they're not getting better, now you're worried that they're failing therapy, then I would do a bronchoscopy. But it turns out that is not the way it usually goes. Usually it's a pretty clear picture. This person's better, everything's better. And then I go, congratulations, your cough is so much better, you can't produce sputum anymore. That's a fantastic outcome.
Great. So you did answer the second question, which was about a patient who's getting better and then all of a sudden they can't produce it. So you follow them clinically, no bronch indicated. But what about for that initial diagnosis? You can't get sputum, you have an abnormal CT.
Yeah, certainly, if I suspect NTM and I cannot get a sputum, then we would proceed with bronchoscopy.
Elisa, the same.
Yeah, a similar approach. I would just add that for a patient that is initially, before they get started on treatment, able to produce expectorated sputum samples, their inability subsequently to have those, to me, would be sufficient to say that they reach that culture conversion kind of mark, right? So if they have positive, 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 and I don't know, a month or 2 months after treatment, their mucus just dries up and they can no longer expectorate, I agree. If all other data points are in the same direction, I'm very encouraged. There are circumstances where one data point might appear to be out of sync with another, and that would be another instance where I might proceed with a bronchoscopy. I think it also has implications, based on the updated guidelines, for treatment refractory MAC and how we approach that. So, failure to eradicate the infection after 6 months, you would want to add ALIS into the mix. And so again, there are situations where I might proceed with a bronchoscopy because some variable is lagging and because it will have an impact on the treatment approach.
Okay. So these the physicians who are sending these in, I assume, or clinical providers are having good success, because this next one is again about a patient who's being treated and all of a sudden their cough is gone, they're better. Do they have to continue airway clearance in those patients?
That's a tough one. I think sometimes yes and sometimes no. It sort of depends on how their scans look. But what I kind of prep patients for when I'm teaching them all about airway clearance is that really some form of this should be considered a lifelong therapy. There are many circumstances where we end up qualifying that, but that's kind of how I prep patients. So what we talk a lot about at every visit is we recognize that this is onerous. We recognize this can sometimes be limiting and constraining in terms of how active you can be. So let's work together to find a version of this regimen that is sustainable, that is manageable for you. And what's manageable and sustainable for you might be different from the next person. But yes, I do sort of tend to prep people. This is one of the best preventative tools that we have in our armamentarium.
Yeah, very good. And I also try to make sure that they don't forget, if they can, that exercise is a very good form of airway clearance. And if they're able to, and they don't want to do some of the other maneuvers, as you said, not one size fits all, then let's get into a very structured exercise program. Okay, so Chuck, these next ones are more towards M. abscessus. Given the importance of macrolides, is there any work on the inhibitors that could allow the use of macrolides in gene expressing isolates? So is there any way, I guess, to manipulate the organism?
Well, Thomas Dick has published data showing that when you combine rifabutin with a macrolide, it may impact the gene expression. So and has shown in vitro that that in fact happens. The activity is better. So I think that's just one example. I'm sure there are probably others that I'm not aware of, but that has caused some people now they're using rifabutin. They're giving both. In Korea, for example, I know one institution there, they give rifabutin and a macrolide to their abscessus patients.
Okay. And the last question I'm going to take before we go on to our last segment is there any role for Bactrim use as a third-line agent for patients with M. abscessus who are recalcitrant?
Lisa, you want to take it?
They're probably asking that because Bactrim comes back on the sensitivity panel in a number of cases.
Yeah, I have not used Bactrim to treat abscessus cases, even when we have very few therapeutic options. I think an important kind of caveat is that much of the in vitro susceptibility testing that we get from the lab is not necessarily predictive of how these drugs work in people. The most classic example being the beta-lactams. You might get very high MICs for imipenem or even for cefoxitin, and yet we know that those appear to have no correlation with how the drug actually performs in the person. But I personally have not used Bactrim and Mycobacterium abscessus. Chuck?
Oh, and just to make the point, but what you usually see that labs have two panels. They have a rapid grower panel and a slow grower. So the Bactrim is in there not for abscessus, it's in there for fortuitum. And so it's the same for the slow grower. The rifampin is there, but that's not for MAC. It's in there for Kansasii. And so I think that confuses people when they see drugs that always come back resistant.
Right. One day we'll get a panel that comes back just for the bug that is growing. I would love that. But for now, we get everything. All right. Thank you so much. I'm going to move on to the last portion of this. Now I would like to take a few minutes just to share about the bronchiectasis and NTM 360, which is actually the bronchiectasis arm of the COPD Foundation. Next slide. So bronchiectasis and NTM 360 addresses a lot of the gaps in patient care. We want to make everybody aware of this, both providers and patients. There's numerous patient resources, a bronchiectasis NTM 360 social online community. There are ambassadors like John that are able to talk one-on-one with your newly diagnosed patients. There's a lot of international awareness. We work with World Bronchiectasis Day, and we have formed the Bronchiectasis and NTM Research Registry in the United States. Next slide. And that registry, as of October 2024, has 24 active registry sites in the US. You can see them on our map there, with over 7,000 patients in the registry, climbing every month. It represents more than 25,000 visits and 16 years of data, and now many publications on the continuity of this disease, what these patients are presenting with, what works, what doesn't work, are coming out in the literature. Next slide. We've gone on to form the Bronchiectasis and NTM Care Center Network. The COPD Foundation will be announcing the first 33 care centers and associate centers probably by next month. It is the plan to have a prompt and accurate diagnosis with high quality patient-centered care and resources so that we can provide 360-degree care for our patients. In the next 3 years, the plan is to have 150 centers in the network that are geographically dispersed across the country with work to ensure inclusion of all communities. Next slide. Here is the steering committee, which I'm very proud to be the chair of. And you can see these are faculty experts as well as allied professionals who work on our team, respiratory therapists and patients who are all involved in bronchiectasis and NTM. Next slide. The timeline for the Care Center Network really just points out that sites are being notified now for our first round, and the second cycle will be opening in February of 2025. If you may be at a place where you would like to apply, just reach out to the COPD Foundation's website. Next slide. Thank you very, very much for listening today. My last plug I want to put in is for the first North American Bronchiectasis and NTM Symposium. If you want to learn more, we're going to have a very comprehensive 2-day symposium at NYU. Just go to NYU CME and you can find our program that will be happening December 9th and 10th in New York City. And we're very excited to be holding that this year. I thank the IDSA for putting this on, and now I'm going to pass it back to Amanda for our closeout.
Thank you. We extend our appreciation to Dr. Ignatius and Daly for your insightful and very valuable presentations. John, thank you so much for sharing the impact that NTM and bronchiectasis have had on you personally. And thank you, Dr. Drizo-Harris, for moderating, and your participation was deeply valued. Thank you to all of our audience for your attendance and participation in the Q&A session. If you wish to revisit this webinar or share it with others, a recording will be made available to you via email on our website and YouTube channel. And make sure you save the date for our upcoming webinars. We will be covering recurrent C. diff in November and HIV treatment in December. If you are interested in becoming a member of the Infectious Diseases Society of America, please don't hesitate to reach out to us or visit the IDSA website at idsociety.org. Thank you again and have a wonderful rest of your day. Thank you. Bye-bye.